Hope I'm audible. If you have any doubts, kindly post them in the comment section. I will take those later on when the chapter is over. So before starting with the pediatric surgery, we are just going to cover up 2-3 topics which were left yesterday from the plastic surgery. So when we are talking about the core plastic surgery concepts, we talked about flap yesterday. So we had made a table of what are the actual flaps are. So flaps can be classified based on the source or what type of flap they are and on the basis of the movement. So on the basis of the movement, the flaps, when they are raised locally, so the flap can be taken up as it is, so a rotational flap or a transpositional flap. So if you can see here, this is nothing but an advancement flap. So when there is a small defect which is going to be present here, what you do is you are going to cut the skin along and you are just going to pull the skin anteriorly. So this is called as an advancement flap. Whenever there is a defect, typically in the region of the scalp, what do? You are going to take a curve incision and you are going to suture it like this. So this is called as a rotational flap. And transposition flap means you are going to take up the tissue and you are going to transpose it here and you are going to close it primarily. So it is called as a transposition flap. You might not know all the details, but the thing is it can be a rotational flap, a transpositional flap or an advancement flap when you are going to take the flap locally. But when you are going to go for a distant flap, it can be either a pedicled flap or a free flap. So in free flap, we checked out that yes, it is a radial forearm free flap or it can be a free fibular flap. And on the pedicled flap, there is a pectoralis major flap or a latissimus dorsi flap. So that's what is given here, a random pattern flap, a rotation flap or an advancement flap. So there is no single vessel here. So it is going to rotate along the blood supply from the dermis. Axial pattern flap, again there is no long artery, but there is a named artery along the axis, but you are not going to take it and displace it at a long place. So it is nothing but a groin flap. The pedicled flap which we discussed, it is transferred intact with the pedicle. So it can be pectoralis major flap, a latissimus dorsi flap or a radial forearm free flap. These are the reliable flaps and they are robust flaps. That is the reason why in plastic surgery they say that when you are going to go for a pectoralis major flap or a latissimus dorsi flap, it is going to be called as a robust flap. What is a free flap? You are going to detach that flap or that tissue from the region and you are going to put it somewhere near the defect. So like a free fibular flap or a radial flap. So you are going to disconnect it and you are going to anastomose it again with the neck. So it is called as a free flap. And a perforator flap where the perforating vessels are there from the deep source. So it is like a deep inferior epigastric flap. So you use these deep inferior epigastric flap typically in breast reconstruction. So when we are going to talk about breast oncoplasty, I am going to tell you about the deep inferior epigastric flap. So when you are taking up a flap, always remember that the muscle blood supply can be divided into various types. So what is that? There are 5 types of blood supply to the muscle, and that muscle penetrating branches are going to give supply to the skin. So if you are going to check it, these are the 5 types of muscle blood supplies. So one is when type 1, type 2, type 3, type 4 and type 5. So type 1 is when there is going to be a single dominant pedicle. A single dominant pedicle is going to be present. In type 2, there is a single dominant pedicle and along with that there are some minor branches which are going to be present. In type 3, there are 2 dominant pedicles which are going to be present. In type 4, there are segmental supply. So it is a segmental supply. There is no single pedicle which is responsible for blood supply. There are segmental branches which are going to supply the muscle. And in type 5, there is going to be one dominant pedicle and other pedicles are going to be segmental. So whenever you are going to check for it, there are 5 types of muscles and the classification is known as Mathis and Nahi classification. So type 1 is a single dominant pedicle and the muscles are tensor, fascia lata or gastrocnemius. So excellent can survive on the single pedicle. In type 2, one pedicle is dominant but other there are minor pedicles. That's what we saw here. So here you can see that one is a dominant pedicle and other are going to be the minor pedicles. So it is nothing but a gracilis or a soleus flap. So gracilis muscle has this type of blood supply. Type 3 means 2 dominant pedicles, large muscles in the body, gluteus maximus and rectus abdominis. So in rectus abdominis we have the superior epigastric and the inferior epigastric artery which are going to supply the muscles. In type 4 it has the segmental blood supply and this muscle is always useless because you cannot take this muscle and anastomose it with a single vessel because there are going to be multiple small perforators. So poor division of any pedicle and hence it can cause a distal necrosis. Type 5 means one dominant pedicle and other are segmental, and this example is always going to be latissimus dorsi and pectoralis major. So the LD flap or PMMC flap are going to be the robust flaps because they have one dominant supply and along with that they have multiple segmental branches. So that is the reason these flaps are irrespective going to survive. So whenever a plastic surgeon is going to reconstruct in a patient who is poorly nourished, who is malnourished, who is not having proper nutrition, that is the time when plastic surgeon is going to prefer this flap, because the flap necrosis is going to be less. Given that, now we are going to come for flap monitoring. Exactly opposite to the graft. In the graft, we saw that whenever you are grafting the patient, you are not going to open any wound of the patient for 5 days, because the blood supply is always passive. It is going to be imbibation, then inoculation and revascularization. Here, the flap monitoring is essential because you are going to anastomose it with some vessel, or the flap is going to be taken up distantly from a pedicle. So flap monitoring is cautiously required for every 48 hours. So graft, no monitoring for 5 days, just open the dressing and check what is going to be happen. But in flap, you are going to monitor the flap for next 48 hours. And how are you going to monitor? Clinical parameters are color, temperature and capillary refill time. So the color of the flap should be normal, it should not turn dusky. The temperature should be normal to as of the body temperature, and capillary refill time should be that of the normal to the body, so less than 2 seconds it should be ideal. If capillary refill time cannot be elicited because of the color change or because of some hair, you can actually go for a pinprick test or a handheld Doppler. So if the pinprick is done and the blood is going to be fresh blood, then it is considered to be okay, this graft is having adequate supply. Then it is the to-gore. So we have to check if there is any edema of the flap, or there is going to be any tension on the flap. So if the flap has become tense or edematous, you have to think that the flap might get hampered. And pinprick test, so as I said, if bright red bleeding is there, then it means that it is a normal finding. If dark blood is there, it is going to be some problematic, and venous congestion might be there, because of which the pinprick test might be failing off. So critical period is first 48 hours, and almost 5% of the free flaps require return to theater. So anytime you are doing a free flap, you should make sure that all the patient parameters are normal. The patient should not be smoking, the vessel should be intact, the anastomosis should be done very well, the blood pressure should be maintained, the nutrition should be good. So whenever you are doing a free flap, the re-anastomosis rate or the re-exploration rates are high, and 60% of the re-explored flaps. So whenever you are going to take any patient, let's consider you do a free fibular flap. So almost 5 patients of the 100 patients needs to be taken to the OT, and out of that, almost, you can say, out of those 5 patients, 3 patients are going to have the normal flap later on with some intervention, but 2% of the patients will have eventually a flap failure. So it is very much important for you to know. Then comes the leech therapy. So typically it is given in Ayurveda. Ayurvedic physicians actually apply leech for many pathologies. But where does the leech therapy come in our practice is when we are treating the plastic surgery flaps. So whenever the flap has become congested, the venous edema which is going to be present, the venous congestion which is going to be present is going to hamper the further blood supply and cause damage. So to actually remove that stale deoxygenated blood, you are going to apply the leech to the flap. And when you are going to apply the leech, what does it have? So typically it has the it secretes the enzyme which is called as hirudin, which is a direct thrombin inhibitor, and hence it causes the anticoagulation at the bite site. So whenever you are going to apply one leech to the region of the flap, what happens is the leech is going to suck out only 5 ml of the blood. But later on, as the leech is going to be removed from the flap, almost 150 ml of reactionary blood loss is going to happen, and you are going to let that blood flow. So whenever that flap is congested, all the deoxygenated blood, the devitalized blood is going to come out of the flap, and that is the reason where the patient is going to improve. And mandatory prophylaxis, because the leech is not sterile organism, it contains an organism which is called as Aeromonas. It contains Aeromonas hydrophila. So another important MCQ point, it is a gram-negative rod which is present in the leech's intestine. So you should give prophylaxis. And which antibiotic is preferred? The quinolone group of antibiotics is preferred, which is a ciprofloxacin. Very much important for us to know. The duration, it should be continued till the venous drainage is established. So what happens is, whenever the venous anastomosis is going to fail, the arterial anastomosis is working, there is going to be edema of the flap, and that flap edema is going to cause the tuberosity and the tense flap, the discoloration of the flap. So you can keep on applying leeches till neovascularization is going to happen, because if the venous supply is not from the proper vein, another small venules are going to develop and re-anastomosis is going to take place sometime later. So whenever you are going to apply a leech therapy, what is the duration for application? So the application is till the time the venous re-anastomosis is established. So getting end to the flap, we have seen the different types of flaps. We have seen the Nates and classification for the muscle pedicles. It is very important. It has came in the NEET SS for 2-3 times. Also it has come in the NEET PG once. So that type of classification is very much important when you are studying surgery. Scar management. So coming down to the scar management, a hypertrophic scar and keloid, we already discussed that in when we were talking about wound healing. So always remember, the hypertrophic scar is within the wound boundaries and the collagen is always linear, and you don't need to worry about it. The silicone sheets are going to take care about it, and usually it is going to regress over 12 to 18 months. In wound healing chapter, we actually saw that the remodeling of the wound takes place for next 3 to 4 years. So that is the time when the hypertrophic scar can regress. So no need to worry about hypertrophic scar. But keloid is a genetic tendency and it is going to extend beyond the wound margin, and it is because of the haphazard collagen, and it does not regress on its own. Hence intralesional steroid can be given or surgical excision can be done. But again, if you are going to excise it surgically, it is going to recur. Hence adjuvant radiotherapy can be used, and a recent advance which we discussed even that time is the cryoablation. Cryoablation can be done for keloid management. A pyogenic granuloma is nothing but whenever there is chronic irritation or some remnant suture material, there is vascular proliferation near the wound site which is going to bleed on touching, and this is nothing but a pyogenic granuloma. So whenever there is going to be a trauma to the finger or trauma anywhere, there is some foreign body remaining, and because of that reaction to the foreign body, there is going to be development of a pyogenic granuloma. So pyogenic granuloma, it is a misnomer. It does not mean it is because of any bacteria. It is because of vascular proliferation, and here you are going to go for a silver nitrate, that is a chemical cautery, or you can go for a surgical excision with the laser. What is a sinus? So typical definitions which are asked in the final year surgery exams. So sinus is a blind-ended tract. So a blind-ended tract which is lined by a granulation tissue connecting any cavity to the epithelial surface. So let's consider the skin is the epithelial surface here, and underlying is the abscess cavity. So whenever a tract is going to lie between these two, it is going to be covered with granulation tissue. And this granulation tissue is connecting the external epithelial surface with the abscess cavity. So this is called as a sinus. It is called as a sinus. Then what is a fistula? It is abnormal tract connecting two epithelial surfaces or hollow organs. So whenever this is the skin and this is the bowel, so whenever there is a tract between a hollow viscous and a skin, then it is called as a fistula. So perianal fistula, enterocutaneous fistula, two openings of rectovaginal fistula. So rectum and vagina can be connected, or two tubes like esophagus and trachea. So tracheoesophageal fistula, very much important for you to know. So always remember why a fistula is not healing. So always remember, why does a fistula not heal? The important mnemonic is friend. I don't believe in any mnemonics, but it was just while going I found out that this mnemonic can be used. So what is that friend mnemonic? So it is foreign body, radiation, infection, epithelialization of the tract, or neoplasm. So what is an important thing? Whenever there is a foreign body inside, the fistula is not going to heal. Because of the radiation, the fistula healing is hampered, and granulation cannot convert, granulation tissue cannot heal, and that is the reason it is not going to heal. Any infection which is going to be present, the bacteria is not going to let it heal. Whenever there is an epithelialization of the tract, so normally I said that it is lined by a granulation tissue, but when granulation tissue is replaced by epithelium, so this becomes a permanent fistula. Now what you need to do is you need to actually debride this fistulous tract. So debride means you are going to probe the fistulous tract and you are going to stimulate the granulation tissue, and that is the mechanism of action of laser or radiofrequency ablation. So whenever a laser is fired, it is going to cause laser debridement of the tract, and then the tract is going to heal by a granulation tissue. If there is any distal obstruction, so let's consider that bowel has some obstruction here, so this tract is not going to heal, because remember, the contents of the bowel are always going to follow the path of least resistance. So what is the least resistance? If the resistance is going to be there distally, all the path is going to drain proximally. So this is called as the dictum of fistula. So what is there? So any bowel, if the distal tract is patent, the fistula should eventually close. So whenever there is a distal obstruction, always never think of repairing a fistula. Same thing while repairing a perineal fistula. If the patient is having chronic constipation, don't repair the fistula, because of that chronic constipation, that fistula will again recur. So always remember, a distal obstruction is always an important point. So here comes the end of the plastic surgery module, and now we are heading towards the pediatric surgery. If you have any doubts, kindly post them in the comment section. I will be more than happy to host you. So now starting off with the pediatric surgery chapter. Pediatric surgery chapter, what I came across is there are many things which are missed out when you are studying in many modules or in many books. Pediatric surgery is not given in detail, but very simple facts are given in many standard books like Bailey and Subiston, which will help us understand the pediatrics better. So whenever you are going to land across any pediatric infant or any bachu when you are handling up, so you should know basic principles of surgery, that's all. The techniques or the surgeries might be the same, but basic way of opening the abdomen, basic way of handling the thorax, basic way of managing the blood loss in a pediatric infant is very much important. So that's what we are going to see here. So firstly you should know that what are the basic definitions. So you should know these definitions. A neonate is nothing but till 28 days. We have seen this in pediatrics, basic pediatrics in our undergraduate level, but here remember that the physiology is immature, and always remember the drug metabolism is also problematic. The same thing which we saw already in our first wound healing chapter, that till the neonatal period all the wounds are going to heal by, yes, they are going to heal by regeneration and not by fibrosis. So fibrosis is not going to be there in the neonatal period. The infant is still 1 year of age, and here there is a rapid growth, fontanelles are open, and the physiology of the child is better because the nasal cavities and the respiratory tract is well developed. A pediatric child is still 12 years. That is the reason why when you are tackling in the big hospitals, if any person more than 12 years of age comes, he goes to the medicine department or surgery department. Less than 12 years, it is handled by a pediatric surgeon or a pediatrician. It is progressive anatomical maturation. So here here the child is going to grow physically, and a young adult or adolescent is 10 to 19 years of age, where the child is also going to mature sexually. So he's going to have a puberty, he can have consent issues or transitional care. So Bailey Love typically states that it is difficult to handle these people with care because these people can actually give their own consent. They are pretty much well read, they understand what is the problem with them. So while dealing with these people, it is always important that you take them as well as their parent or guardian into consideration. So it is also important in view of medico-legal implications. So this is a very good table which I came across. This is a table which I have made typically after seeing all the textbooks, because there are some physiological parameters in the children which are going to change our surgical approach to the child. So what is that? So first remember the head size. The head size of the baby is 20% to that of the total body surface area as compared to 9% in the adult, and that is the reason major heat and fluid losses occur via evaporation from the child. And that is the reason whenever a newborn child is born, the grandmother is typically going to say that cover the head of the child, rest of the body comes later on. So why do we cover the head of the child? Why do we cover the head? So that is because the head size is proportionally larger than that of the adult. So it is 20% rather than 9% of an adult. What is abdominal orientation? So in adults, what happens is the abdomen is going to be vertically long, but in child it is opposite. It is going to be transversely long, and that is the whole reason that you are going to make transverse incisions over the abdomen of the child. So while actually seeing the type of incisions in general surgery, we discussed that we are going to take incisions based on the Langer's lines. But along with that, exposure is the first important factor. So in adult, a vertical midline incision or a vertical incision is going to give better outcomes because you can access all the organ cavity. But typically in the child, a horizontal incision is preferred because the child's abdomen is more transverse than vertical. So transverse incisions on child. So whenever you see a pediatric surgeon operating, you are going to see that the incisions are always going to be transverse. What is the liver position? The liver position is always going to be below the costal margin. So whenever we are going to see the rib cage, a normal adult liver is usually situated inside the costal margin, and liver is not usually palpable. But in a child, the liver is always palpable because the liver is more than that of the costal margin. The liver is grown out of the costal margin. What implication does it make? Whenever you are going to do any surgery to the liver for biliary atresia or for any gallbladder or bile duct surgeries, always make sure that in adults, we take the incision just below the costal margin. So in adults, we are going to take the incision just below the costal margin. But in the child, make sure that the incision is made 2 centimeters at least below the costal margin. Because when the child is going to grow, this scar is eventually going to come to the subcostal region. The thoracic cavity is going to grow and it is going to come down to cover the liver. We are going to see the respiratory movements in the child, how they are going to be different. And the costal cartilage, when the costal margin is going to grow down, automatically the liver is going to go inside the costal margin. So always place an incision at least 2 to 3 centimeters below the costal margin, because if you need to explore the child later on in the life, you can go from the same scar. Or else you will have to first make an incision in the child here, and second incision will come at this place, and then the tissue between it may undergo necrosis later on, and the scar healing would be poor, and there would be a lot of problems to the child. So always remember, when you are tackling a child with this, you should always take care about it. So subcostal incisions are placed below the liver, and abdominal trauma is most likely to the liver. In adults, we saw that most common organ injured might be the spleen, but here the most common injured organ in the blunt abdominal trauma is going to be liver. Umbilicus. So umbilicus is low lying in infants. So normal umbilicus is the normal umbilicus distance 2/3 to 1/3. So upper 2/3 and lower 1/3 is the normal margin. Umbilicus is placed behind that. But in infants, the umbilicus is actually lower, and hence stoma placement must be carefully planned, because we know when we are going to talk about stoma, we will talk about stoma triangle. So stoma triangle is umbilicus, pubic symphysis, and ASIS. Between that, you are going to do a stoma. But in the child, you should make sure that you are actually calculating the umbilical distance as well, because it might hamper the stoma placement. What about the ribs? The ribs are horizontally lying, and that is the reason I told you that the liver is going to come down. Later on, the ribs are going to crowd vertically, and that is the reason when the liver is going to go up. So they lie horizontal, and that is the reason the ribs movements are not much in a child. So a child is doing more work by the diaphragm. So diaphragm does the more work of breathing of the child. And remember that always in child trauma, unlike adults, a rib fracture might not be there even if the pneumothorax is present, because the ribs are very much pliable. The ribs can actually bend, and that is the reason they can damage the pleura and again get back into their position. So most of the times, as occult pneumothorax might be missed, because you might feel that the X-ray of the child is normal. There is no rib fractures. Omentum. So always remember that it is underdeveloped. In adults, you know that wherever there is going to be a pathology, the omentum is going to go. It is called as a policeman of the abdomen. But in child, the omentum is not very well formed till 5 years, and that is the reason any intra-abdominal pathology is going to cause full-blown peritonitis. There is not going to be a time where there is going to be a localized peritoneal pathology. Let's consider an appendicitis. The appendicitis, the tenderness is in the right lower quadrant. In cholecystitis, the tenderness in the right upper quadrant for adults. But in child, the omentum is not going to cover it. Omentum is not going to help in reducing inflammation. So a child will always land up into full-blown peritonitis. Intestinal anastomosis. Remember that the lumen of the intestine of the child is very much narrow. So in adults, usually we prefer doing a double layer anastomosis, but in child the healing capacity is more. So single layer of anastomosis, and that to extramucosal sutures. So always remember, single layer extramucosal sutures are preferred, because they are going to make sure that you are not going to compromise the lumen. Because the intestine's diameter is very much small, there might be obstruction later on. And the blood volume, which is important, that in child it is 80 ml per kg. So when a child is born, of around 4 kgs of child, the only blood volume is going to be 320 ml. So if you calculate the blood loss according to adults, in adults it is like till 450 ml class 1 shock. In child, 320 ml is the whole blood volume of the child. So even 50 ml of blood loss to the child is very much hamperment. So small volumes, 20% loss is also considered as a significant hemorrhage. So 20%, if you consider of 300, it comes down to somewhere around 50 to 60 ml. So 50 ml of loss in a neonate is also considered to be a massive hemorrhage of the child. So always remember that when you are dealing with the child, these are the few things which are very much important: the work of breathing, the rib cage, the costal margin, the incision lie, the stoma placement, the umbilical placement. So these are the things which are different in child than in adults. So according to that, you are going to make sure that you are going to place the incisions on the child. Fluid and electrolytes. So hyponatremia is very much common in child. So hyponatremia is common in children but is dangerous. In adults, hyponatremia can still be tackled. Hypernatremia is considered to be very dangerous. In the child, hyponatremia is very dangerous because the blood-brain barrier is not developed. Hyponatremia, a lot of fluid shift happen and it can cause cerebral edema. Hence, always remember that no hypotonic solutions to be given to the child. That's what is given in the orange box. No hypotonic solutions should be given to the child as post-operative maintenance, because there is a risk of iatrogenic hyponatremia and diffuse cerebral edema. So no hypotonic solution should be given. So DNS is contraindicated in the child always. So whenever you are going to go for a child, whenever you are going to ask for IV fluids of the child, they are always going to give NS and they are going to add potassium to it. They will not prescribe a DNS to the child because hyponatremia is worst in a child. Surgical stress releases ADH and it will cause relative euvolumia and hyponatremia. So many times surgical stress, as in adults, same is going to happen to the child. So when ADH is secreted, the sodium will relatively become low, and that is the reason a child might present like a hyponatremic episode. And sodium, potassium are required 1 millimole per kg. It is like an adult, and cerebral glucose requirement is also same like an adult, 2 gram per kg per day. So hypoglycemia is dangerous in neonates because the neonate has limited glycogen reserves. So whenever you are going to operate any patient of the child, make sure that the child is not starving. So that is the physiological and surgical differences in the anatomy between a full-blown adult and a child. So hope it is clear to you, and then we are going to proceed to the further chapter, which is going to be common pediatric surgical conditions. So first important thing which we are going to tackle is going to be inguinal hernia and an hydrocele. So this is the basic minimum requirement for any undergraduate to know how are you going to tackle these basic surgical conditions in a child. In NEET PG, they are very well asked again and again in the paper, what is the ideal time for surgery, what is the ideal procedure for surgery. So basics you should be knowing about it, irrespectively you might take pediatric surgery later on or not. Basic things are basic and you should be knowing it. So inguinal hernia, always remember males common than females, because the spermatic cord is going to descend to the scrotum, and the right testis is going to descend much more later than the left testis. Hence inguinal hernia is more common on the right side. So it is because of the patent processus vaginalis. While talking about the inguinal canal anatomy, I am going to tell you how the inguinal canal develops. So the testes are located in the abdomen, and when it goes down into the scrotum, it is going to carry all the abdominal layers along with it, which are going to be modifications. So for example, skin is going to convert, yes, you know, the skin is going to convert into the rugosity of the skin. The deep fascia of the anterior abdominal wall, the campus and the scarpa's fascia which is present, not the deep fascia, it is going to convert into the dartos muscle. The external oblique is going to cover into the external spermatic fascia. The internal oblique is converting into the cremasteric muscle. The transversus abdominis is converting into internal spermatic fascia, and the peritoneum is going to be covered into the processus vaginalis. So that peritoneum which is going to be carried along is ideally supposed to be closing. But if that peritoneum doesn't close, then the defect is going to remain patent, and from that the bowel might herniate, or omentum is not developed well in child. So bowel herniation is very much common at this age, and if it becomes incarcerated, you can attempt a gentle reduction. Whenever a child is going to present to you with an inguinal hernia, it is going to be an enterocele unless otherwise proved. Because the omentum is not developed, bowel is going to slip down into the inguinal hernia content, and elective herniatomy should be done. And always remember, it is only herniatomy. The problem is the processus vaginalis has not closed. There is no muscular defect in the child. So problem is with the peritoneum, only deal with the peritoneum. So cut the peritoneum which is going into the inguinal canal and ligate the peritoneum and leave the things as it is. You don't need to do any type of reconstruction in a child. So it is called as a plain herniatomy. So in child you are just going to do a plain herniatomy. So plain herniatomy is important, and it is very much important. So there are many theories why does this happen. So it might be problem with the CGRP gene, calcitonin gene related peptide. It is very detailed, you don't need to go into it. It might be again because of something which is called as a gubernaculum defect, problem with the hormones. So they say that the testes descends late, and that is because the hormones fluctuation, there is formation of inguinal hernia. So these are the theories behind it. We don't need to go back into the theories. Our basic thing is how are we going to manage the child. Hydrocele, always remember that it can present to all the infants before 2 years, because there is going to be some reactionary peritoneal fluid. It might be communicating with the abdominal wall. It is called as hydrocele of the hernia. It is called as the hydrocele of the hernia. It is called as hydrocele of the hernia. So there is a hernia, but bowel is not coming, but peritoneal fluid freely comes and goes. So it is called as hydrocele of the hernia sac, and it is present many times in the child. Ideally, it will obliterate by 2 years on its own. If it does not obliterate, then you can consider for surgery. So hernia, bowel enters, it becomes irreducible, it is an emergency. And in hydrocele, it is just a fluid content, you can wait and watch. So hernia, any hernia presenting to you after the age of 6 months, any hernia you are going to operate. But hydrocele, you are going to ask the patient to wait for 2 months. Now we are going to coming down to what is called as undescended testes. So undescended testes or cryptorchidism. So few textbooks say that bilateral undescended testes is cryptorchidism. But few textbooks are saying undescended testes is equal to cryptorchidism. So jaisa des, वैसा बेस. If examiner asks us about proper definition, then say it is bilateral. If they say who told you bilateral, oh sorry sir, it is unilateral. So you should know how to tackle it. My thing of telling you is undescended testes is nothing but cryptorchidism. Normally, where are the testes located? So the testes, if they are not descended, the most common location of an undescended testes is going to be the Dennis Brown pouch. Sir, where is the Dennis Brown pouch? So it is going to be between the abdominal fascia and the external oblique muscle. So this is your abdominal wall and this is going to be your internal oblique muscle, and between it is going to be the fat. So this is the fat. So normally the testis, most common location of the undescended testes is going to be here. So just outside the external oblique aponeurosis, between the abdominal fat and covered by the skin. So this is going to be the normal anatomy near the superficial inguinal ring. So it might be present at the superficial inguinal ring. What happens is, because of the hormonal imbalances, there might be some problem. And hence the descent is delayed, or sometimes the baby is born early. So baby is born early, a premature infant is born, let's consider by the age of 8 months. So the child is premature, so the testicular descent might not have occurred. So always remember that you should correct the age of the child. So let's consider a baby is born at 8 months and now the child is only 4 weeks old. So you cannot consider that this child is equivalent to the child who might have born at 9 months. So always calculate the corrected gestational age. So always it is important while dealing with cryptorchidism to go for corrected gestational age. So corrected gestational age you are going to take out, and always remember that 6 to 12 months you can wait, maximum of 6 months or maximum of 12 months, minimum of 6 months, and you are going to operate the patient within 6 to 12 months before irreversible damage is going to happen to the germinal epithelium. So within 6 to 12 months, the chances of infertility are going to reduce significantly. That the testosterone might be produced irrespectively, but if you are going to operate within 6 to 12 months, then the changes which are going to happen for spermatogenesis, those changes are going to be reduced. Also remember that these testes are most likely to develop a seminoma in the future. So the cause is actually not known. So they can cause malignancy, a testicular malignancy, typically a seminoma, 4 times more. So 4 times increased risk of malignancy typically in these patients. So it is very much important that you are going to do a surgery irrespectively. Let's consider a child comes to you at 16 years of age with undescended testes. You will be like, oh God, there's no use of doing surgery because already 12 months are lapsed. There is no return of fertility. But here make sure that you do a you operate that cryptorchidism and get the testes into the scrotum, because the testes might not be functional, but later on in life if the cancer develops, it should not happen that because of the retroperitoneal presence it is noticed later on. So whenever a malignancy is going to be present, immediate increase in the size can point out towards malignancy. So for you to detect the cancer early, for patient to be cured early, you can straight away go for the orchidopexy, that is fixation of the testes in the scrotum, as soon as possible. So optimal time is 6 to 12 months. Stephen Fowler's procedure. So what is a Stephen Fowler procedure? We know that the testicles are supplied by testicular artery and testicular vein. So whenever the testis is in the retroperitoneum and the testicular artery and vein length is going to be very much less, then that testis cannot be get down into the scrotum. So how do we deal with it? So because the retroperitoneum has rich blood supply, what are we going to do? We are going to ligate the testicular artery and vein in the first attempt. So we are going to go inside, we are going to find the testes. We see that the testes is actually having a small length vasculature. So just ligate them and you are going to leave the testes as it is. After say 6 weeks to 6 months, what happens is the actual blood supply from cremasteric muscle, from the vas deferens artery, so that blood supply is naturally increased and testis is now surviving on the cremasteric blood supply. So when the testis starts to develop on the cremasteric blood supply, that is the time you are going to take the testis down into the scrotum. So that is called as a Stephen Fowler 2-stage orchidopexy, which is frequently asked in the exams. So Stephen Fowler is 2-stage orchidopexy for high intra-abdominal testes. Divide the spermatic vessels in stage 1 and allow the collateral supply to develop, and then you can go for the patient in stage 2. And associated risk is a gastrochisis. We are going to see what is gastrochisis. So most commonly associated congenital anomaly is gastrochisis and undescended testes together. So very much important to know. How are we going to actually treat the patient of cryptorchidism? So whenever a patient is going to come to you after 6 months, so cryptorchidism management. So if it is less than 6 months, you can go for hormonal management. Hormonal management is still under trial, and there is no class 1 evidence that the hormonal giving hormones to the child will actually cause the natural descent of the testes. But if the child is more than 6 months old, then you are going to see if the testis is palpable. So testis palpable or testis non-palpable. So if the testis is palpable, you can straight away go for palpable, means it is likely in the inguinal canal. You should go for straight open orchidopexy. You can go for orchidopexy. But if it is not palpable, according to books, what are you going to do? You are going to go for a diagnostic laparoscopy. In India, we don't straight away go for a diagnostic laparoscopy. First, we'll go for an ultrasound, then we might do an MRI because CT scan has high radiations. So you might do the investigations. But according to the book, as it is, you are going to manage that undescended testes after 6 months. So straight away go for a diagnostic laparoscopy. So we are going to go for what is called as a DLAP, diagnostic laparoscopy. And here you can actually see two things. What are the two things which you are going to see? That the testis is present or testis is absent. So if testis is present, then you can decide if 1-stage or 2-stage surgery. So whatever is feasible according to the length of the testicular vessels. But if you are going to see the absent testes, you can actually look out for the vasculature from the abdominal aorta. But if it is again not going to be present, if it is present, then you can find the testes and go for it. But if the vasculature is going to be absent from the abdominal aorta, then that is the time when you are going to get the click that this might be something else. So either the testes might have undergone the intra-abdominal torsion itself. So one thing is intra-abdominal torsion, which is rare. But the second important thing which you should know is the patient might be a pseudo-hermaphrodite, that there might be some Klinefelter syndrome XXY, or there might be something which is called as an androgen insensitivity. So many times there are the syndromes wherein the patient might be having loss of sexual function. So it is very much important. So always rule out pseudo-hermaphroditism. So you can go for a karyotyping to rule out genetic defects. So this is a basic principle and flowchart of management of cryptorchidism, and here the cryptorchidism is over. So now we are going to talk about some benign scrotal diseases which are very much commonly encountered, and as a general surgeon you should be able to manage them because they are going to happen after 2 years. So after 2 years the baby is going to improve. So already saw what is going to happen. So whenever the baby is going to increase in age, the physiology is going towards more and more towards the adult side, and you can manage these conditions being a general surgeon. So first important thing is a testicular torsion. So usually occurs between 12 to 18 years of age, and it is always an emergency. So don't wait for a Doppler. So never wait for a Doppler for confirmation of diagnosis. You can go for a scrotal exploration. Sir, what are the clinical signs which can be present because of the testicular torsion? Because of the testicular torsion, the testes, let's take a ball and hang it on the string. So whenever the string is going to be rotated, the ball is going to come slightly up because of the torsion. Because the length of the testicular vessels is going to reduce, the ball is going to be slightly up. So in the same manner, there is going to be a high riding testes. The testes is going to be slightly lifted upwards, and there is going to be an absent cremastric reflex. This is the pathognomonic two signs of the testicular torsion, and Prenz sign is not a pathognomonic sign. Prenz sign, what is Prenz sign? So whenever in cases of epididymoarchitis, what happens is because of the inflammation of the cord, the testes is kept dangling, and that dangling testes is going to call pull to the cord, and that cord is going to pain. So whenever you are going to give some rest to the cord, whenever you are going to lift the testes slightly, the tension on the cord is reduced, and that is the reason why the pain is reduced in epididymoarchitis. That is called as a Prenz sign. But here in testicular torsion, this sign is going to be absent because it is not related to inflammation. It is related to the infarction, and surgical exploration is always to be done and always remember, if right-sided testes got into torsion, you are going to fix both the testes because the left testes might also undergo torsion later on in life. So if you are exploring the patient, you are going to do a bilateral orchidopexy. So whenever you are suspecting a torsion, straight away explore the patient on clinical judgment, and you can go for orchidopexy. The only indication is if the Doppler is within one hour. So if you can get a Doppler within 1 hour till you are going to prepare the patient, it is fine. But if you are not having a Doppler, don't rely on the Doppler. A clinical judgment is more than enough for go for a scrotal exploration. A testicular appendage torsion. Most of the times the pain is as severe. But significant clinical thing is the patient does not present with vomiting. Apart from testicular torsion, which is going to present with sudden abdominal pain with vomiting, here vomiting is going to be absent, and whenever you are going to go for an exploration, you will find a blue dot sign, because if you see the testes, there is going to be something on the top of the testes which is called as the appendix of the testes. So that undergoes torsion and it becomes blue in color. So it is called as a blue dot sign, and here the cremasteric reflex is present. So that's why I said high riding testes with cremasteric reflex absent, think of torsion and straight away explore the patient. And it is analgesia plus self-limiting condition with rest. You don't need to do anything more for a testicular appendage torsion. Epididymoarchitis mostly happens in post-puberty. So usually after 20 years of age, in 20 years of age, in Western countries, people become sexually active. It happens now also in India, but in Western countries, mostly after 20 years of the age, then there is infections, UTI, and it causes cryptorchidism. So pain with scrotal erythema. So even there you can see some amount of scrotal swelling. Why scrotal swelling is seen? Because there is reactionary inflammation of the tunica. There is inflammation of tunica vaginalis. So almost there might be some amount of hydrocele also present in the patient, and patient might have urinary symptoms, and pain is relieved by scrotal elevation, which is the Prenz sign. So Prenz sign is very much important, and cremasteric reflex is always present. So cremasteric reflex is always present. And here you are going to go for antibiotics with scrotal support. That is more than enough. So antibiotics and scrotal support is important. Why scrotal support is important? The dangling cord is going to cause pain to the testes. So always support it with the scrotal support. And then comes one condition which is going to be seen in slightly younger age group, 5 to 7 years of age, which is called as idiopathic scrotal edema. The idiopathic scrotal edema, that it is being given in many places, right from Bailey Love, right from urology, right from super specialty books. So what is idiopathic scrotal edema? Because of some allergens, there is some scrotal skin edema. That it has nothing to do with the testes. Even if you do the Doppler, it is normal. So child will persistently keep on complaining about the scrotal pain or discomfort, and we think that there might be some pathology in the testes. So we get a CT scan, MRI, USG, everything is normal. So it is called as idiopathic scrotal edema. It is bilateral edema, and the treatment of choice is going to be antihistaminics. It is going to be antihistaminics, and it usually can progress to perineum, and the testes is absolutely normal on all the investigations. So you should know this. So this is cryptorchidism. So as you can see, this is the abdominal testes, this is the inguinal canal testes, it is the high scrotal testes, and this is the normal condition. You should distinguish this condition which is called as a retractile testes. So retractile testis is nothing but the cremasteric reflex is hyperactive. So whenever you are going to touch the thigh of the patient, the testis is going to jump into the inguinal canal, but it is again going to come back into the inguinal canal when the child is going to be at ease. So always remember that retractile testis needs to be ruled out before you are labeling the child as cryptorchidism. And this is called as an ectopic testis. When the testis lies along its normal path, it is called as a undescended testis. But when the testis is not actually there along the path, it is somewhere else, then it is called as an ectopic testes. So it might be superficial ectopic, it can be in the prepenile region, it can be in the femoral region, transverse scrotal region, or it can be in the perineum. So these are all the sites for ectopic testes, which is important for your long answer questions. Then comes another condition which is called as an umbilical hernia. So umbilical hernia is very much common. Why? Because it is a natural defect. We know that when the child is developing, when the midgut is developing, all the contents are going to come out of the abdominal cavity. The bowel is going to increase, and again that bowel is going to be taken out with the help of intestinal rotation. So that bowel is taken inside the abdomen 270 degrees counterclockwise rotation. So that is very important to know that 270 degrees counterclockwise rotation happens, and the bowel is taken up inside the abdominal cavity. But whenever this abdominal cavity, the bowel is taken, the defect from which the bowel is herniating might be present. So an umbilical hernia might be present in the child when the child is born. And always remember that it is extremely common. It is extremely common when you are dealing with umbilical hernia, and especially in the Afro-Calibrian children. Majority close spontaneously by 3 to 4 years of age. So again, as I said, hernia, inguinal hernia operate whenever you are going to see. Hydrocele, wait for 2 years. Undescended testes, 6 months. Umbilical hernia, you can wait for 3 to 4 years. But sir, what is the indication to operate the hernia? When you should consider operating to the hernia? So when the hernia is enlarging or the diameter is more than 2 centimeters. So whenever the diameter is more than 2 centimeters, there might be a risk of bowel obstruction. And always remember, as in hernia we did only herniatomy, the problem here is only going to be the facial defect. So no need of mesh, no need of reconstruction, just a plain Mayo's repair. So what is the Mayo's repair? So this is the abdominal wall, this is the abdominal wall, this is going to be the umbilical hernia defect. What do? We are going to release this sheath from above and from below, and then we are going to do the double beresting of the sheath. So the inferior flap is going to be placed here, and the superior flap, the inferior flap is going to be placed here, and the superior flap is going to be pulled down, and it is going to be anastomosis like this. So the defect is now covered with two layers of sheath. First the inferior sheath and the superior sheath. It is called as an anatomical repair, which is also called as a Mayo's repair. So when to repair the hernia? If the age is more than if the centimeter, so the diameter is more than 2 centimeter by the age of 2 years. So when it is there, you should repair the hernial defect. And also if the proboscis is more, what is the proboscis? Whenever the child is standing, whenever the child is going to stand, the hernia is going to protrude. So this proboscis, if this proboscis is going to be more than 3 centimeters, that is the time when you should operate the patient of umbilical hernia, or else there might be some skin necrosis later on in the life, which will lead to ugly looking scar. Very much important thing. Again, when to operate is important, will come for MCQs in NEET PG also, and might be asked you in your final exams. What is IHPS? Infantile hypertrophic pyloric stenosis. So whenever the pylorus of the child is going to be hypertrophied, the child cannot tolerate the feed. And remember, initially there is no hypertrophy. So when the child is going to be born, initially he can accept the oral feeds. But later on in life, let's consider for after 2 weeks, after 3 weeks, there is going to be progressively intolerance to the feed, and child is going to vomit out whatever you are giving him, maybe breastfeed, maybe water, maybe any type of feed. The child is going to, obviously you don't feed the child water, but whenever you are going to give the child breastfeed, the breastfeed is going to be vomited out, and it is progressive in nature. So by 2 to 6 weeks of life, the child is going to start having the problem, and male to female ratio is 4:1. So again we saw that in inguinal hernia the male to female ratio was 5:1. Here the ratio is 4:1, and first born male childs are affected. Typical statements for the NEET PG exams. This is how the question is always asked. So progressively developing vomiting in a male child who is first born male child in the family, it is IHPS. Don't need to apply any logic to it, it is IHPS. How is it going to present? It is going to present progressively with non-bilious projectile vomiting. Obviously the bile is not going to come, and it is the hungry baby after the vomitus. So after the baby is going to vomit, the baby is going to feel more hungry, because the vomiting is not because of any metabolic problem, it is not because of any intestinal obstruction. The baby intestines are not getting any content, so the child is going to be crying of hunger. So when you feed the child, it vomits, again it cries of hunger. Mechanism, so what happens exactly? Because from the stomach there is going to be loss of hydrochloric acid, so it is going to be loss of H plus and Cl minus. So these things are going to be lost from the vomitus, and because of losing of H plus, the patient is going to land up into alkalosis. So how is kidney going to compensate? The kidney will ideally compensate by excreting the bicarbonate. So that is the ideal mechanism for compensation. But what happens? Along with that, another negative charge is going through the body, that is chloride. So when the chloride is lost, the negative charge in the body is reducing. So the kidney is like in the dilemma. What should I do? Should I lose the bicarbonate or should I keep the bicarbonate? So kidney decides to keep the bicarbonate to neutralize this Cl minus. So there is going to be HCO3 retention. So HCO3 minus is going to be retained. And this condition is called as hypochloremic, because the chlorine is low. Hypochloremic metabolic acidosis. Hypochloremic metabolic acidosis, because H plus is going out, Cl minus is going out, but kidneys are still preserving bicarbonate. Why? Because negative charge is low, and with paradoxical aciduria. So as the HCO3 is not getting excreted in the kidneys, the urine is also going to be acidic. So if you are going to excrete acid from the nose, naturally the kidney should excrete base from the urine to keep the body normal. Acid is going to reduce, so the base should reduce. So kidney should remove the base, but kidney is not removing the base. Kidney is also excreting acidic urine, less of bicarbonate. Why? To manage the negative charge. So whenever you are going to manage this patient, you should first make sure that the potassium is corrected. So HCl is lost, chloride is deficit, the kidney retains stored HCO3, and it causes more alkalosis. Diagnosis is ultrasonography, which is going to show the muscle thickness more 4 mm, and the length is going to be more than 16 mm. So it is a square of 4. So if you remember, 1:4 is the female ratio, 4 mm is the muscle thickness, and square of 4 is again 16 mm. So that is the length of the hypertrophic muscle. How are you going to manage the patient? So one important line is, it is not an surgical emergency. It is not a surgical emergency. It is a metabolic emergency because the chloride in the baby is low. We already saw that small change in the osmolarity of the child, it is going to cause a lot of damage to the blood-brain barrier. So never take the alcoholic baby to the theater. So it is the take-home point from today's lecture. In IHPS, don't take the baby to the theater. First correct the electrolytes and operate when the baby is normal. So whenever a NEET PG question is going to come, a baby presents with vomiting dash dash dash, what is the next line of management? So the next line of management, if it comes, it is going to be resuscitation of the baby. But if it is going to come, what is the definitive management? Then the management is resuscitation, fluid resuscitation, and then comes the definitive management, which is Ramstead pyloromyotomy. So you are just going to cut the muscle and you are going to release the obstruction. Just muscle, not the mucosa. So the mucosa is not going to be released. You can do it open or laparoscopically, and again remember, do not cut the mucosa. So definitive management is surgery, but preliminary management is when you are going to resuscitate the baby. So this is the very important thing. Let's go to the diagram. You will get to see here. So this, you can see that this is the 60. So this is the 16 mm length. This is the 4 mm muscle thickness. So this thickness is going to be 4 mm. So I hope it is clear to you. This is the length. This is the thickness of the muscle. Same thing which is seen on the ultrasonography. So the radiologist is going to actually check for what is called as the length of the muscle, which is 16 mm, and the height of the muscle, which is 4 mm. So this comes to the diagnosis of IHPS. It is also called as CHPS. Why CHPS? Congenital. But they found out that it is not congenital. It does not appear at the time of birth. It is progressive. Hence its name is now changed from congenital to infantile, because it is going to happen in the infant. So it is an infantile hypertrophic pyloric stenosis. Now coming to the another condition, which is called as an intussusception. So what is intussusception? We know that telescoping of the bowel segment into one another. This is the bowel segment. From that, the posterior bowel segment is going to go inside it. So this is called as telescoping of one segment into the another. So whenever the bowel segment, so let's consider this is a long bowel segment. What happens is, it is going to go inside the next bowel segment. So this bowel segment is going to go inside. It is called as an intussusception. We are going to talk about detailed intussusception when we study small bowel. But here in child, it is important to know that in child, the most common intussusception is ileoileal. Few books also say it is ileocolic, because what happens is, most common intussusception, why does it occur in the child? It occurs because the child is having what is called as a Peyer's patches. So Peyer's patches are going to enlarge. Typically in the post-viral condition, the child might have running nose, the child will have reactionary lymphadenopathy. So whenever there is a lymphadenopathy in the neck, same lymph nodes are going to be swollen in the abdomen. There might be mesenteric lymphadenitis. Along with that, there might be ileal Peyer's patches hypertrophy, and that is the reason where the intussusception is going to happen. Which virus? Most commonly adenovirus, and that Peyer patch acts as a lead point. So ileoileal intussusception can occur. What is the classical triad? It is the colic abdominal plane plus red currant jelly stools. So what happens is, the fecal matter is going to get stagnated here. The fecal matter is stagnated here. What is going to happen? Some amount of mucosa along with the bleeding is going to slough off from this region, and it is going to typically be seen as red currant jelly stools. Red currant jelly stool. So it is like a red sauce. Typically, if you have seen those pickles, those very thick pickles, it looks like that. So there is mucus and PR bleed, and palpated sausage shaped mass in the right upper quadrant. Why in right upper quadrant? Because in case of ileoileal or IC intussusception, the bowel is pulled up into the right upper quadrant, and that is the reason you can feel the mass in the right upper quadrant. So the triad of intussusception is nothing but, yes, it is going to be colic abdominal pain, it is red currant jelly stool plus mass in right upper quadrant. So this is nothing but intussusception. And how are you going to manage? It is because of inflammation of Peyer's patches. So conservative management should ideally be given. So you can go for an air pushing. So when you are going to push the air from here, then the intussuscepting segment will naturally go back because of the pressure of the air. So whenever you are going to push the air, whenever you are going to put a catheter and insert the air inside the cavity, this is going to push the segment outside. So that is the pneumatic decompression. If it does not occur, you can also instill gastrographin. Gastrographin is hyperosmolar contrast. It is going to absorb the water and reduce the edema. So when the edema is going to be reduced, naturally the segment will naturally regain into the position. So that's what they have said. Pneumatic air enema can be given, or hydrostatic USG guided enema can be given. So you can insert a catheter under a USG guidance and you can see where it is going, and then you can push the enema from that. It is an alternative to air enema and has similar success rates. So 70 to 90% success can be there just with the help of this type of conservative management. But if the child fails or if it recurs, so if it recurs or if it fails, if these two are going to fail or if they are going to recur, then you are going to go for a surgery. And even if there is going to be some indication of peritonitis, or you think that the segment is obstructed and then it is perforated, then you can go for a surgery. Again, open or laparoscopic is done. So always remember, never pull the segment. So as I said, this is going to be the intussusception. You are never going to pull this segment. Always remember that you are going to push from here. So always push the intussusception segment outside. Don't pull it outside, because if you are going to pull it, the bowel might be teared. So gently push it from the intussusception side. So gently push it. And bowel resection is required. And again, non-viable bowel, if you find it during surgery, you can go for a resection. We have seen that extramucosal single layer anastomosis should be done in the child, and there you can go for an ileocolic resection with primary anastomosis. So few books are going to tell that ileal is the most common type in the child, and few books are going to say that it is ileocolic. For NEET PG purposes, always remember ileocolic should be the answer. But when you are going to go into your PG, then ileal can be the answer if the examiner is fond of international books. So here we are going to come to an end of the chapter of general pediatric surgery. Tomorrow we are going to start talking about the neonatal surgery. So when the child is a neonate, that is for first 28 days of life, what presentations can the child be and what type of surgeries are required in that child. So we are going to talk about the neonatal surgery. I think there are 5 minutes left, so we can just cover up one module of biliary atresia. If you guys are bored, you can leave the meeting and watch recording later on. But I think we will try to cover just a biliary atresia module and then we are going to stop. So what is biliary atresia? So whenever a child is born, the child has what is called as a physiological jaundice. The child is normally jaundiced when the child is born. But whenever a child is born, ideally that jaundice should go back within 14 days. So jaundice should go back within 14 days. If it does not go, then, or if the child is having grey colored stools, it means that the bile is not getting excreted in the intestines properly. And that is the reason the child might have something which is related to the obstructive jaundice. So you do a USG and you find out something which is called as a biliary atresia. So biliary atresia can be broadly divided into 3 types. What are the 3 types of biliary atresia? Type 1 is when below the common bile duct is fibrosed. The common bile duct is fibrosed, that is the type 1. In type 2, the common hepatic duct is also fibrosed. So type 2 and type 2B. So basically till the confluence, everything below is not functioning. And in type 3, everything right from the right to left hepatic duct, everything is fibrosed. So the type 1 biliary atresia. So what is type 1? Is when the fibrosis is just limited. The fibrosis is limited below cystic duct. So it is nothing but CBD. So when the hepatic ducts are also involved, it is going to be called type 2. And type 3 means individual right and left hepatic duct also involved. So that is the type of biliary atresia. So type 1 is common bile duct obliteration, which is distal. Type 2 is hepatic duct, and type 3 is proximal bile duct near the porta hepatis. It is the most common type. So whenever you are going to see this, the timing is critical. Why? Because as you are going to delay the surgery, after 8 weeks, the liver is going to go for a toss and liver transplant might be required directly. So whenever you are dealing a patient with a biliary atresia, make sure that you are going to take the decision within 8 weeks. Within 8 weeks, the decision should be taken. We already saw that when you are making an incision 2 centimeters below the costal margin, because the scar will go up because of the costal margin later on, and a secondary exploration might be required. So what is Kasai's portoenterostomy? I am going to tell you. And even after a successful surgery, 70 to 80% eventually are going to land up into a liver transplant in the adulthood. So whenever the child is going for a surgery for biliary atresia, even after a successful surgery, 70 to 80% of them will require liver transplant in the subsequent adulthood. So what happens is, let's see, if the duct is normal till here, what I can do is I can actually cut all this specimen and I can actually do an anastomosis. This is a common hepatic duct. I can do an anastomosis with the bowel. So it is called as hepaticojejunostomy. So the hepatic duct is anastomosed with the jejunum. It is called as hepaticojejunostomy. But if the right and left hepatic ducts are also fibrosed, I cannot do a hepaticojejunostomy. So what do? I am going to cut both the ducts at the inferior surface of the liver. So this is the inferior surface of the liver. This is the porta hepatis, and I have cut the right and left ducts. I can see those here. So what do? I am going to take a bowel loop and I am going to make a big hole on the bowel loop, and I am going to anastomose the bowel loop here. So I am going to anastomose the bowel loop here. So what is going to happen? Whatever the bile is going to be drained without going into the ducts, it is going to straight away come down into the bowel. But mind you, this is not a physiological procedure. It is called as portoenterostomy. So bowel is anastomosed direct with the porta hepatis. So it is called as a Kasai procedure or portoenterostomy. So when you are going to go for a portoenterostomy, it is not going to serve the purpose. Most of the times it is going to require a resurgery, and if you are not going to do it within 8 weeks, almost the 10-year survival of the child is going to reduce. And if you are going to do it after 12 weeks, the child is only going to live, the survival till 10 years is going to be less than 20%. So early referral is critical. Even if you are operating at a peripheral center, you think that this is a complicated case, straight away refer during first week, second week itself, because after 8 weeks, a delay is going to cause 50% mortality in the child, and 12-week delay, a 3 months delay is going to cause 80% mortality in the child. So always remember, what is portoenterostomy? We have seen what are the types of biliary atresias, that also we have seen typically. So I hope it is clear. From tomorrow we will start off with the necrotizing enterocolitis and other congenital conditions. Till then, if you have any doubts, you can post it on the Instagram or WhatsApp group. I'll be more than happy to help you out. Thanks for attending today's lecture, and I'll see you tomorrow evening. Thanks.